Welcome, everybody, to today's podcast. Today, we are talking about Minoxidil, the comeback kid. And with me and Dr. Han is Dr. Ken Anderson. Dr. Anderson probably needs very little introduction, but I'll give you one briefly. He is founder and director of the Anderson Center for Hair. He's board certified by the American Board of Hair Restoration Surgery, the American Board of Facial Plastic and Reconstructive Surgery, and the American Board of Otolaryngology, Head and Neck Surgery. And he's a diplomat of the American Board of Hair Restoration Surgery, one of the top hair restoration surgeons in the world, a very sought-after speaker. And we're extremely privileged to have you with us, Dr. Anderson. Thanks so much for making the time today and for everything you do. We look forward to today's podcast. Sharing the panel with me is Dr. Christina Han, XYON's medical director, an experienced dermatologist who does see a lot of patients with hair loss in her practice. Thanks, Dr. Han, for your time. And I'm Simon Pimstone. I'm a founder and CEO of XYON Health. We're a e-com company dedicated to offering the best services and products for men and women suffering from hair loss. So welcome to everybody. Dr. Anderson, thank you. And I thought I would really kick off at a fairly high level, Dr. Anderson, with just a bit of a background to Minoxidil. It's an interesting drug. It's came out of actually the cardiovascular world, which is my prior world, and was used, as we know, for the treatment of hypertension for many years. Can you give us a bit of a background as to how this old drug became a drug of interest for the treatment of hair loss, and also perhaps talk a little bit about how we think Minoxidil works in its activity against certain forms of hair loss?
Sure. Of course I would. Thank you very much for that introduction. It's a pleasure to be here with you both, and thank you for having me as a guest on the podcast. It's wonderful to be here.
Right.
In terms of Minoxidil, so yeah, the comeback kid. In the 1970s, Minoxidil was used as a drug to treat hypertension, typically in the cardiac intensive care units, as I understand it, a little bit before my time in terms of medical training. Sometime around 1980, the early 1980s, they noticed that patients that were on this on Minoxidil started growing hair in other areas of their body, on their arms, on their body, on their legs, sometimes on their face, an effect called hypertrichosis. And then so they did a bunch of studies in the mid 80s to sort of examine the dose of Minoxidil and what would achieve this hypertrichosis effect. And I think in 1988, 2% Minoxidil was formally approved for male pattern hair loss, and a few years later, I believe in 1992, it was approved for female pattern hair loss. Now, I should note that the doses used for hypertension were much higher in the 25 to 50 milligram a day dose, but the dosages, at least orally, for the treatment of hair loss are much lower in the 2.5 to 5 milligram range. In terms of how it works, it's interesting. Its exact mechanism of action is not precisely known, but we do know that it is a potent vasodilator. That means it causes arteries to expand slightly and increase blood flow. And this increased blood flow delivers more oxygen, nutrients, and growth factors to the hair follicles. The effect of this is that it prolongs the anagen phase, or the growth phase of hair follicles, which is the time they spend most of their time in, and it shortens the telogen phase, which is the resting phase that hair follicles undergo. So if you have a greater proportion of hair in the growth phase that it's being extended, and a smaller proportion of hair that's in the resting phase, when the hair is technically shed, you're going to have clinically a fuller head of hair.
Yeah. Thanks, Dr. Anderson. And I think your point is well made. The precise mechanism of how this works is unclear. We know Minoxidil is a potassium channel modulator as well.
That's correct.
And there may be some activity through its K-channel mechanism. What's also been shown is induction of VEGF, as you mentioned, a growth factor, which helps in maintaining the size of dermal papilla, which is also very important. But the exact mechanism as to how this works, which is quite distinct from the 5-alpha reductase inhibitors, which have a very precise mechanism of known action, is probably not well understood. But as you point out, probably vasodilatation and delivery of the good stuff to the dermal papilla and the hair follicles is really underlying this. Dr. Anderson, you did talk a little bit about the approval of minoxidil initially, of course, in a 2% form and then in a 5% form. We'll get to the oral in a moment, because obviously that's kind of a source of great interest, particularly since a New York Times article published not that long ago. But let's stick with the topical for now. Do you typically use the 2% or the 5%? And do you typically use a solution or a foam? I think there are a lot of questions that often come in from our customers, as to which is better and which is the better sort of administration form. Is it the solution or is it the foam? Maybe you can comment on the percentages you typically use, and then what type of topical typically you would instruct your patients to take.
Well, very good. So yes, the strength of minoxidil that I recommend for patients, both men and women, is the 5% minoxidil. I actually don't recommend the 2%. There has found in studies to be a greater response to the 5%. I think that there's not a huge difference between the foam and the liquid in terms of its clinical efficacy. The main difference that some patients find is that because often it's thought because of the propylene glycol carrier in the solution or the liquid form, some people can have a local sensitivity to that on their scalps where they apply it. The foam uses other carriers and not the propylene glycol, and so is sometimes more tolerated in patients. The exact hairstyle of the patients can come into play. Sometimes patients will just decide they like the liquid or the foam better for those reasons. So, but yeah, I stick with the 5% minoxidil for sure.
And then I think looking for fragrance-free versions probably important, as well as instructions to apply to the scalp rather than the hair, which I think is another question we get.
That's exactly right. Yeah, I do tell my patients. I said, I tell them the minoxidil, it doesn't need to be in the hair. Put it on the skin. Make sure it's on the skin.
Exactly. What do you typically tell patients regarding shedding, Dr. Anderson? And is shedding observed similarly with minoxidil as it might be observed with the 5-alpha reductase inhibitors?
Great question. So I do counsel my patients about shedding. About 10 to 15% of patients are going to notice some initial shedding in the first couple of months. This is should not be of a concern. Okay, it's understood that what I want the audience to know is that all follicles at some point shed their hair. The follicle is the little cellular factory that makes the hair, and it goes through cycles. The anagen phase, as mentioned earlier, is the growth phase, and on the scalp at least, the follicle stays in the anagen phase and produces a hair for a solid 3 to 8 years. And then it goes through a regressive phase called catagen, and then it enters the telogen or resting phase, where the hair has already been shed and it doesn't produce any more hair for typically 3 to 7 or 8 months. And then every follicle after that resting phase re-enters the growth phase and produces a new hair. So patients sometimes call me up, and again, 10 to 15% of patients will notice some early shedding. Really, I just tell them that's kind of a sign that it's working. It is affecting the timing of the hair cycles. It's kind of like when you plant a tree, sometimes the leaves will shed temporarily. So I tell them that that hair will come back, and hopefully it will come back stronger. So it's sometimes in a minority of patients can be a bit of an annoyance at the outset of treatment, but I tell my patients to stick with it. That hair is coming back and the shedding will stop.
Yeah, and Dr. Han, in your own practice, I mean, you must see shedding as a common sort of fear and worry from your patients on various forms of treatments for hair loss. Do you counsel similarly? I mean, you do have this anxiety as patients lose more and more hair in the first few months that it's going to continue.
Yeah, and I absolutely agree with Dr. Anderson. You absolutely have to counsel, because I think this is something that's very discouraging to see and anxiety provoking. And if you don't preemptively discuss this with them, then it can be a reason for discontinuation of therapy. And so I certainly agree. It's often temporary, lots of reassurance, and a potential expected side effect as well. So not permanent, and a lot of handholding and guidance along the way.
I always wonder, for both of you actually, and I don't have the clinical experience that you both have, is when you see quite profound shedding, is that and I don't think there's ever been a clinical study that's looked at this, but might that actually be a sort of a surrogate for what kind of response one might actually imagine in a positive sense? In other words, if you're let's call it a high shedder early with the treatment, might you be expected to respond very well to that treatment, or is it actually irrelevant from your experience, the degree of shedding and how the patient responds to the treatment? Are they dissociated?
Well, I think there is some association, but I think the degree, I don't think anyone's looked at the degree of shedding and the efficacy of the medication, but I do think it would make sense that if there is some early shedding, that patient is definitely going to have a response. There is a small a minority of patients are not going to have a large response to the minoxidil used topically because of a lack of an enzyme called sulfosyltransferase in the scalp. And so that's a minority of patients, however. I will say that you touched on, Dr. Han, you mentioned patient compliance. I have, when I talked, so at the Anderson Center for Hair in Atlanta, of course, I see patients every day. And I really take time with the patients. There needs to be, there's a lot of misperceptions or misconceptions about hair loss. There's a lot of nonsense, frankly, on social media. And so the appointments are an hour long for a reason. So we can explain to the patients and have a discuss. It's more of an educational experience for the patients. And I have an analogy I use with patients, and that is that I ask them to consider that hair loss is like dental decay in many respects. Okay, it's a phenomenon that has no known cure. It's lifelong. It's progressive in nature, and it requires daily treatments and of significance. Not just preying on it or taking a multivitamin to effectively try to prevent. The other thing that it shares with dental decay is no change is a good thing, right? Because of the progressive phenomenon of hair loss, if you don't do anything, we would expect less hair in, say, a year. And so this, when I hear sometimes from younger guys, I stopped using the minoxidil because I didn't see anything. And I say, well, you get a gold star if you don't see any changes. So I tell them at a minimum, just know that it's been proven to work and to keep using it. Do not stop using the medication if you don't see anything, because if you stop, preventive care for your hair loss, you're going to experience more hair loss. It always, once it starts, it never stops.
Yeah, absolutely. And the degree of progression may be very rapid in some. And those are people you really want to intervene early and quickly. I totally agree. I think we always talk about family history also being an important predictor, and I think we see that in many chronic disorders when there's a high burden of that disorder in the family. And I refer to hair loss as a disorder. It's not as such, but for some people, certainly it's an inherited phenomenon. If there's a high burden of that in the family, the likelihood of that individual going through rapid and or severe hair loss is obviously much higher.
I do want to point out, though, and it's not always. I've seen over the years many patients come in and they're like, I've got 5 brothers, they all have hair, I'm the only one. So it can skip around genetically. It's not Mendelian genetics, and also it doesn't come from your mother's side. Like that's an old wives' tale. A lot of people believe that, but that's not true as well. But certainly genetics do obviously androgenetic alopecia, which is the term for male pattern hair loss, is certainly genetic based, but it can be frustrating for anyone with the phenomenon.
Yeah, I think for people to understand, genetic risk doesn't mean that it's a determinant of a disease. It means it's a risk factor, and you may develop the condition, but you may obviously have factors in your case that prevent it. I'm going to have Dr. Han take on a number of the questions on oral minoxidil, because that's obviously a really interesting sort of new addition to the puzzle. Would love to get your thoughts around that. There was, just perhaps before I hand over to Dr. Han, there was a very interesting New York Times article published a couple of years ago now, almost a couple of years ago, around the use of oral minoxidil, which really propelled the use of the oral formulation. Of course, to your earlier comment, had been used pretty much solely as an antihypertensive. And then because of this hypertrichosis, which for the audience means, increased hair growth in other body parts, was noticed. The use of this has become much, much more ubiquitous. So Dr. Han's going to sort of, I think, deal into how you use oral minoxidil, so-called off-label, when you use it, what doses in your male patients and female patients. But did you see that article? And just maybe you can give some color and commentary on that. Have you seen an explosion of interest in oral minoxidil, even incoming to you from your patients?
Yes. So I've been, as mentioned, treating hair loss patients. That's been the focus of my career for over 20 years. And when that article came out in, it was August of 2022 in the New York Times, and they actually mentioned in the article that the oral minoxidil worked better than the topical minoxidil. It says it right in the article. And so when that happened, I did see a lot more requests for oral minoxidil from my patients, certainly.
Right. And now I'm going to hand over to Dr. Han, but that last point is a really important one, and perhaps the audience to know. There have been some small studies that have comparative studies looking at topical versus oral minoxidil, showing some degree of greater benefit with oral finasteride. With oral, with oral. But it's these studies have been small, and we don't yet have a really large, well-controlled study. But there is certainly, I'd say, when you speak to doctors, the experience that the oral minoxidil may have a preferred benefit over topical. Dr. Han, I know you've got a lot of questions on oral minoxidil for Dr. Anderson, so why don't you take it away?
No, thanks for that. That's a good segue, because I too have seen a surge in interest and requests from patients on oral minoxidil, and even some coming to me with a specified dose that they want to be on, because they are becoming more informed. And of course, as you know, hair loss is a devastating problem that many of our patients sometimes go in the rabbit hole of the internet and come across things like this New York Times article. But I absolutely have seen a surge in its requests from patients. And I also do use quite a bit of low dose oral minoxidil in my male and female practice. So I guess to you, Dr. Anderson, how do you sort of discuss oral minoxidil in the low dose form for your patients? And is this something that you just use as requested by patients, or is this something that you go from topical minoxidil? How do you go about sort of implementing this in your algorithm for treating androgenetic alopecia?
Very good. So thank you for the question. Well, I actually prefer to prescribe topical minoxidil. It's sort of talked about at the hair restoration surgery meetings that I've been going to around the world in the last several years, that they're about the same in terms of efficacy. And actually, a study came out just last month in the journal in JAMA Dermatology. Dr. Ramos out of Brazil, he looked at 90 patients and had them separated. It was a highly controlled trial. It was placebo controlled and double-blinded, meaning the patients didn't know if they were on the placebo or not. The people administering the study didn't know, and the people evaluating the results didn't know if the patient was on the placebo or not. And they compared topical with oral minoxidil. They did not find statistically significant differences. However, they did find non-statistically significant differences in that the oral minoxidil slightly outperformed the topical medication, but not to a significant degree. So it's not something that you can hang your hat on. I do think that because of the side effects that can occur with the oral minoxidil, headache, heart palpitations, low blood pressure, that you can just get around that entirely using the topical medication, because so much less of the medication is absorbed systemically. So I will typically counsel my patients to use the topical form, because you get basically the same effect, but you avoid the side effects. And I will also add, I don't really ever use it as a monotherapy. Okay, there are.
You mean in the topical or the oral?
Either, yeah. You're not. Hair loss is a powerful disorder, and especially with younger patients under the age of 40. Those patients have decades of living to enjoy, and decades of as currently incurable hair loss to contend with. And you always want to use surgery as a last resort, minimize the size and number of surgeries patients are going to have over the course of their life. So you want to save all the follicles that you can. And so I'm literally never saying, okay, take some, use some minoxidil and call it a day. There's topical finasteride, laser caps definitely work. Photobiomodulation is a proven therapy that I think works well with topical medications as a sort of a going back to the dental analogy. I tell patients, I'm like, here's your toothbrush. Here's your dental floss every day. These are 2 daily activities you got to do for your hair loss: the laser cap and the topical medication. So those are my thoughts on that.
One of the interesting thoughts around the clinical studies, including the one you mentioned, Dr. Anderson, is many of the studies for assessing hair loss responses look at the response at a 6-month time point at 24 weeks.
That's exactly, yep. And as is true with this study.
As is true with that study. And, I think while we all agree that one should start to see an effect at 6 months at that time point, a maximal benefit probably takes longer with all forms of therapy. And the literature is filled with this, and probably around 12, and in some cases even 12 to 18 months. So I've always felt in my own mind are the endpoints set at the right time frame? And I'm not to go down this rabbit hole today, but obviously if you're looking at a 6-month time frame, while there may be benefit, it may not have achieved statistical significance. You may need a much larger cohort size to show it in a smaller time frame. I think your point is a well-made one, though. Small study, maybe some degree of benefit, but certainly in this study, no statistical meaningful difference between the topical and oral minoxidil. And so from your standpoint, you still look to go for topical as your first choice versus oral. And given some of the side effects more associated with oral than topical, that's another factor. Perhaps to you and Dr. Han, back to you, Dr. Han, just around side effects of oral, because I think that's of interest as well.
Yeah, I think Dr. Anderson touched on the main ones that I also talk about. Headache, edema to the hands and feet can certainly happen. Hypertrichosis or unwanted hair in other sites. This is definitely a problem for some female patients, but many of them overlook this because they really do want to grow hair, and they'll look to do hair removal techniques in other areas like facial hair. And palpitations, certainly, and lightheadedness and dizziness because of hypotension or low blood pressure can certainly occur as well. So these are all things I counsel my patients on. I also do avoid the use of this in someone that is family planning. So if they are pregnant, planning pregnancy, or breastfeeding, I will not use oral minoxidil, but I will use topical minoxidil in women after their first trimester of pregnancy, if they're willing to go on it. So that's sort of what I do. And I don't know if Dr. Anderson, you have anything else to add with regards to counseling on oral minoxidil?
No, I think you covered it. The peripheral edema. Rarely you can get pericardial edema. I do, and I want just to back to what Dr. Pimstone mentioned. And that is that, the maximum effect from minoxidil is seen after typically at least 12 months. So these studies that are just, evaluating at 24 weeks are not getting the full scope of the effect of the medication.
Yeah. And this is the biggest challenge in I think in consulting with our patients, which is the importance of persistence and the time that this takes. This is a slow process.
Another thing I think is certainly doable with oral minoxidil certainly is dose titration. It's harder to do with topical minoxidil unless you're compounding at higher percentages, which some do. But do you sort of have a maximum dose that you will use for your female and male patients in terms of the low dose oral minoxidil?
Yes, I know some doctors are willing to go up to 10 milligrams a day, but my personal limit is 5 milligrams. I tend to be more of a conservative doctor. Oftentimes, I'll start patients out on 2.5 milligrams to make sure they can tolerate that, and then after three months or so, consider going up to the 5 milligram dose.
Yeah, that's what I do too, but I'm actually even more conservative in my female patients.
Oh, yeah?
And I sometimes will start at 1.25 milligrams for my female patients, just because of the fact that many of them are younger and often are on the lower blood pressure side. But that's nice to hear that that it's very similar. I don't go to 10 milligrams myself either.
And possibly just a comment just to remind the audience, oral minoxidil is not approved for the treatment of androgenetic alopecia. It's used what we call off-label, which essentially is when the physician determines it's in the best interest of the patient, factoring in other factors, to use a treatment. Treatments are often used off-label, but it's very important that those discussions happen between the patient and the doctor makes that decision in the best interest of the patient, either because of tolerability concerns with other treatments or presumed better efficacy with this off-label treatment. So I think that's just an important point to clarify. This is not an approved treatment for hair loss, but is used widely off-label based on these interactions.
Okay. Dr. Anderson, I had one more follow-up question. Do you do any investigations when it comes to oral minoxidil use? Like, do you work up with any baseline or laboratory testing or ECG? I do not, but if assuming the patient is otherwise healthy.
Yes. Well, okay. So most of the patients nearly 100% of the patients that I see in the clinic do not have serious cardiac or renal disease. The minoxidil is metabolized in the kidney. So if a patient comes in that has on dialysis or has some serious kidneys issues, I would probably defer to their nephrologist about the use of minoxidil. And if a patient has had a history of some cardiomyopathy or pulmonary edema or pericardial effusion, something like that, or are on a significant number of hypertensive medications and have a significant cardiac history, I may ask for a letter from their cardiologist just to get medical approval for the medication. But that's fairly unusual in my practice. Yes.
Thank you for that.
And I imagine in those settings, Dr. Han and Dr. Anderson, one might consider a topical preferentially first, just given the presumed lower systemic levels of minoxidil.
Absolutely.
Yeah.
Absolutely. Yeah. So that's
for sure.
Absolutely. As I mentioned earlier, I prefer that in my practice.
Yeah.
I think we covered much of the topics, but one thing I did sort of want to get your expertise on, Dr. Anderson, is in the female patient that is considering going on systemic treatment for their hair loss and are considering oral minoxidil. Do you ever use it in combination with oral spironolactone, another off-label hair loss medication?
No, I don't have much experience with that. For whatever reason, I would say 5% or less of my patients are female.
Okay.
I mean, I don't, obviously it's an elective practice and people, these patients are technically ill. And so it's not like I see a cross section of patients with illnesses. So the patients self-select to come see me. And so no, typically I haven't experimented with that or haven't used that in my practice as of yet.
Dr. Han, what about in your practice? Do you tend to use in your female patients combination minoxidil, finasteride, spironolactone? Where do you stop and start in terms of these combinations? Because I think what is generally thought is that for women's androgenetic alopecia or female pattern hair loss, it's a more complex phenomenon, and polypharmacy or multiple medications are often considered as an approach versus a simple sort of monotherapy in men.
Yeah, and I think my practice is very different than Dr. Anderson's. The majority of my patients are going to be female. And so I do have quite a lot of experience using oral spironolactone. It can be quite efficacious. Of course, I use it as well off-label for acne as well in the female patients. So I have lots of patients on spironolactone in general. And, some patients don't respond. So that's when I will sometimes add in minoxidil. Most of these patients are young and female. And so as long as they're not planning pregnancy and are tolerating medications, I will do a combination approach. I tend to not use finasteride in my female patients of childbearing potential. And I certainly will also even try to avoid it with topical finasteride as well in this demographic. But yeah, it's always nice to chat with and get different perspectives because, of course, it sounds like we do have different practices. I think, sometimes the saying of throwing the kitchen sink at something definitely rings true for hair loss patients. And you said it really nicely. I think these are patients that you really want to preserve as much of that follicular unit as possible. I trained Dr. Anderson, I think, with Dr. Jerry Shapiro.
Yeah, of course.
And, he would always say that hair loss is a trichologic emergency, really honing in on, the
that sounds like Jerry.
Yeah, that hair loss can be, of course, a very devastating psychological and physical illness. And so, certainly that sense of urgency has been instilled in me in my training. And, as you said it well, the goals of therapy is not just regrowth, but keeping and maintaining what you have. And I think I definitely am a huge proponent of that, because setting that expectation early on and getting patients to understand that this is going to be progressive, and this is certainly a guaranteed progressive condition without treatment. So,
well, here's something else that the one I mentioned earlier about the analogy to dental decay. There's two big differences. One is that not everyone has hair loss, but everyone has dental decay. But the thing that fools most patients is the rate at which the phenomenon occurs. Yeah. Okay. With dental decay, it's a little bit every day. And if you took a graph and plotted amount of dental decay versus time, it would be a straight line down. It doesn't vary day to day. It can a little bit with diet, but you know what I mean. What I have found in the past 20 odd years is patients will come in with, having had hair loss, but maybe not in the last few years. And so they want a transplant. And so, okay, we're going to talk about the transplant. And then when I talk to them about prevention of future loss, they tell me, I've had this same hair for 5 or 8, 10 years. And so what I impart on these patients is that once it starts, it never stops. Hair loss will accelerate and decelerate throughout life. So that if you made that same graph with time on the x-axis and plotted the amount of hair loss, it would stair step its way down. And it fools patients because they think I've lost all the hair. You got a 60-year-old guy. He's like, I've lost all the hair I'm going to lose. And I have patients coming in who start having hair loss at the age of 65. And so it's really important that patients understand that when you combine that fact with the fact that transplant, really, there's only a limited number of follicles you can transplant over the course of your life. And it's not a ton. People are born with about 55,000 follicles on their scalp. And, over the course of several surgeries over many years, you might be able to transplant maybe 8,000 follicles. The numbers are not in the favor of the hair loss patient. So prevention is critical because we want to preserve that, what we call a donor bank of follicles, and treat it valuable, like something in the bank. So it just further underscores the need for prevention, which is really literally how in patients with androgenetic alopecia, that I see, which are 99% of them. Of course, there's other types of hair loss, but for the typical male and female pattern hair loss, the first thing I talk about with 100% of patients and spend quite a bit of time on in the consultation is prevention, educating them about the various things really we've talked about on this podcast today, and to help them understand the nature of hair loss. I actually published an article in the forum, the International Society of Hair Restoration Surgery's journal, about the hair loss dental decay analogy, because a lot of patients think, they'll ask me, and I'll go, what happens when I stop using the minoxidil? Is my hair going to fall? And I said, well, what happens when you stop brushing your teeth?
Yeah.
And then, and I can see sometimes a light bulb. They're like, oh. Now, some patients will say, do I have to, I also recommend laser caps. And some patients will ask, do I have to use the minoxidil or the laser cap forever? Now, here's an interesting feature of hair loss, and that unlike with dental decay, right, there's not a lot of research going on about how to prevent dental decay. We got to floss, we got to get the brush, go for cleanings. It's really one thing: get the plaque off the teeth. We figured it out. With hair loss, there's a lot of research going on, and I feel that within the next 5 to, say, conservatively 15 years, there's going to be a breakthrough in the arena of regenerative medicine, that we can administer an as yet uninvented treatment, that it'll be a situation kind of like dental cleanings. You go see a guy like me or Dr. Han once every 4 to 6 months, and then the treatment is performed, the injection or whatever it is, and that will prevent future hair loss for, say, 95 or 98% of patients. I think that's coming. So I that's sort of the silver lining for my patients when I let them know that this is probably not forever, but in 2024, this is what we got.
It's actually very interesting, and this is a fantastic sort of way to end, I think, and you've summarized sort of the field with such important points here, Dr. Anderson. It's actually quite interesting when you think about how long the problem has been with us, how relatively little innovation has been brought to it, in terms of, medical therapies and or approaches. And so the hope, as you put it, is there may well be some type of regenerative cellular genetic approach that in time has an ability to really transform the landscape of treatments. We have what we have for now. And I think the important points that you and Dr. Han have made today is, use what we have today the right way and at the right time, because I think letting hair loss progress and proceed makes that treatment all the more difficult in both male or female pattern hair loss. And so I think you've really hit on this message, which we're trying to put out a lot, which is it's about prevention, like most conditions. It's like exercising. To your point, it's brushing and flossing. It's getting ahead of the curve. I think that's so important in hair loss. Anyway, Dr. Han, thank you for your thoughts today, and Dr. Anderson, really appreciate this so much from both of us. Your wisdom on this topic has been incredible, and I think communicated in such a great way for the audience. So hopefully we get to talk with you again soon. There's lots more to do together, and we're excited to do that. And I will just remind our audience, thank you for tuning in. Our next topic is going to be hair transplant surgery. We're going to talk about techniques, considerations, and myths. It'll be another wonderful event, but I'm sure we'll be getting to talk with Dr. Anderson again in the not too distant future. So thanks to everybody. Take care.
Well, I really appreciate it. Treating hair loss is my passion. I love talking about this stuff. So yeah, always more than happy to join and discuss with you these interesting topics.